Assalamu alaikum. My name is Itfa Ahmad and my roll number is BB1650096 and my course number is 705. Today I am discussing the topic which is cyclosporin. First, I would like to tell you about some details of what cyclosporin is. Cyclosporin is a calcineurin inhibitor and a lipophilic cyclic peptide. It is an immunosuppressant with efficacy in human organ transplantation to prevent rejection. Cyclosporin reduces the activity of the immune system by interfering with the activity and growth of T cells. It is used for the treatment of autoimmune disorders. Now, here I would like to tell you that in which conditions we use cyclosporin. Cyclosporin may be used alone or in the combination with other immunosuppressants. Particularly glucocorticoids, it reduces or suppresses the strength of immune system. Cyclosporin is used to prevent transplant rejection in people who have undergone kidney, heart, and liver transplants. It is also used for the treatment of rheumatoid arthritis, severe psoriasis, and as an ophthalmic emulsion for the treatment of dry eyes, which is called as restasis. It is also used in some severe skin conditions, which is severe atopic dermatitis, Kimura disease, pyoderma gangrenosum, chronic autoimmune urticaria, and asthma. Now, here are some side effects and adverse effects which this drug can cause and can affect the health of patients in various ways. Because cyclosporin is an immunosuppressant, it may cause patients to vulnerable to other health problems because it is very toxic. Its use can cause high BP, kidney problems. It is also encourages cancerous growth. Other side effects are headache, vomiting, nausea, diarrhea, upset stomach, cramps, increased hair growth, tremors, swollen red gums, dizziness, unusual lumps, night sweats, swollen glands, vision changes, chills, problem in speaking or walking, and weight loss, etc. Now, this drug is available in different dosage forms. We will discuss what these dosage forms are. In capsule form, it is available in 3 doses, that is 25 milligram, 50 milligram, and 100 milligram. It is present as an oral solution in 100 milligram per ml. Also, it is present in injectable solution, that is 50 milligram per ml. Now we will discuss that what dose should be given to different group of patients, that is adults, pediatrics, geriatrics, renally impaired patients, patient with pregnancy or lactating, and other groups. So first of all, we will discuss what dose adjustment should be given for adults. Now here are some scenarios in which we will adjust the dose. That is, first we will discuss in organ transplantation which dose should be given. In oral, 4 to 12 hours pre-transplant, 50 milligram per kg by oral for 1 dose divided twice in a day. 1 to 2 week post-transplant, 15 milligram per kg per day by oral divided twice in a day. We should reduce 5% dose per week until 5 to 10 milligram per day by oral divided. In IV, we will give 4 to 12 hours pre-transplant, 5 to 6 milligram per kg per day by oral divided twice in a day post-transplants, and can tolerate oral therapy 5 to 6 milligrams per kg IBQ day. For patients with severe inflammatory flares or psoriasis or recalcitrant psoriasis, start with maximum dermatological dose of 5 milligram per kg per day administered over 2 doses. As soon as the patient is no longer in distress, the cyclosporin can be decreased in decrements of 1 milligram per kg daily every 2 weeks until the minimum effective dosage for maintenance therapy should be obtained. The third category is for patients with chronic plaque type psoriasis. Start with 2.5 to 3 milligram per kg per day. If improvement has not occurred by 1 month, increase the cyclosporine dose by 0.5 to 1 milligram per kg daily every 2 weeks as necessary, but not to exceed maximum dose of 5 milligrams per kg. The other group of patient is for pediatrics. 14 to 18 milligram per kg pre-transplant by oral, 12 to 2.5 to 0 milligram per kg post-transplant twice in a day for 1 to 2 weeks. Maintenance dose is 3 to 10 milligram once in a day by oral. Recommended for the children above the age of 6 months. For geriatrics, this drug is not recommended for elderly patients because it is such a toxic drug that it can cause harm to other organs in elderly patients as they are more vulnerable and have weak immune and have weak body. Now, moving on further, we will discuss the pregnant and lactating mothers. This drug is not recommended because it can cause serious harm to the developing fetus and also has the ability to excrete through the breast milk. So it can be harmful to the child. For renally impaired patients, this drug is not recommended because it can cause infection and it is toxic to kidneys. The use of these drugs along with the other drug are toxic and should be closely monitored. Therefore, its use is not recommended for the kidney patients. For patients with liver problems, this drug can cause liver damage if we take it in high doses. Now, here we will discuss some drug-drug interactions, that what drugs have capability to interact with cyclosporine. So then we should avoid these drugs while giving cyclosporine. It interacts with a number of drugs such as erythromycin, clarithromycin, phenobarbital, rifampicin, digoxin, uromab, levostatin, simvastatin, etc. Now we will discuss that if we take in excess amount or lower than required amount, then what happened and what toxicity can cause this drug. Cyclosporin and related drugs selectivity inhibit adaptive immune system responses by T-cell dependent biosynthesis of lymphokines, particularly IL-2 at the level of mRNA transcription. Cyclosporine is metabolized in the liver by P450 enzymes. Drugs that affect the P450 system also affect the metabolism of cyclosporine. Hypertension is the most common side effect of cyclosporine. Its nephrotoxicity is functional rather than anatomic, caused by the constriction of the afferent renal arterioles. Bacterial and fungal infections are less common in patients. However, cyclosporin-treated patients are more prone to viral infections. Now, we will discuss the different brands available in market with its pharmacoeconomic point of view, that which drug is cheaper as compared to the other drug and which one should be buy. So here are the two alternative drugs which are present in the market. And first one is Sandeman Neural, 100 milligrams, have 50 capsules in one strip. In 50 capsules, and the price is 9,900 rupees. Gangraf is 25 milligram and have 30 capsules, and its price is 4,030 rupees. The price of these are quite expensive because it is an expensive drug, but as compared to Sandeman, Gangraf is cheaper. Alternative drug we should give is the tacrolimus, which is the best alternative drug of choice in case of cyclosporine because of its effectiveness and efficiency to treat the disease. Now, what happens if we use too much or too low, too much or too less cyclosporine, which can cause irrational use of cyclosporine? Irrational use of cyclosporin can lead to following problems. If taken in higher doses, cyclosporin can cause liver and kidney toxicity. It can also increase the risk of certain type of cancers, such as lymphoma and skin cancer. Moreover, it also causes hypertension and other infections. Now, we will discuss the case study regarding cyclosporin. Um, so that you can have better understanding of what cyclosporin plays a role in specific disease. Mr. MJ is a 50 years old man, came to the dermatologist with a 3-day history of not feeling well and redness of all skin associated with desquamation scaling. The condition started in his extremities and face and then rapidly spread over his entire body. He also complains of swelling of his arms and legs with severe pruritus. 5 years before, he came to the hospital with well circumscribed erythematous plaque with silver scale over the elbow and scaly scalp. He clinically diagnosed with plaque psoriasis and had been treated with typical corticosteroids and moisturizing creams. Now, his chief complaint is redness of all skin associated with desquamation scaling. Now we will discuss about our patient, that is his age is 50 years old. And then 5 years ago, he came to the hospital with circumscribed erythematous and plaque with silver scales over the elbow and a scaly scalp, tension headache, and no other chronic illnesses he have. PMH that a patient's medical history that he has been treating with topical corticosteroids and moisturizing cream and NSAIDs, and his PSH is negative. Now we will talk about his social history. He is a married man and a bank manager. He does not smoke, drink, and does not use any IV drugs. And also there is no history of his recent travel. He doesn't have any history of blood transfusion, though he has a history, family history of psoriasis, and also he doesn't have any allergies to food and drugs. Now, our objective is that first of all, we will examine thoroughly the patient. First, we will classify our examination into 3 parts. First one is systemic, second one is general, and the third one is dermal examination. In the systemic examination, we ask patient about his all the organs, if he has any chronic illness or not, if all his organs are working properly or not, or does he not have any underlying condition. So we asked all these questions about his body, and he told us that he doesn't have any chronic diseases or not any problem regarding any organ, but he does have arthralgia and joint swelling. Our journal examination is the patient is obese. His body temperature is 38.6 degrees. His pulse is 92 bpm. His respiratory rate is 16 breaths per minute, and blood pressure we monitor is 120 by 88 milligram HD. His oxygen saturation is 97% on RA. Now here, as you can see, the picture of his condition. By dermal examination, we diagnosed that the erythema is spread almost all of his body, including face and trunk. And limbs. In addition of the thickening of the skin, the thick scale is present on the scalp and nails too, and also there is swelling, rigidity, and pain in the elbows and knees. On the way now, our diagnosis, we came to the conclusion that on the basis of journal, dermal, and systemic examination, the patient is diagnosed with erythrodermic psoriasis. Our differential diagnosis is that the other skin conditions he has with this disease is lichen dermis, erythrodermic psoriasis, atopic dermatitis, erythema multiforme, and Stevens-Johnson syndrome. Now, our assessment is that this patient has been the patient of erythrodermic psoriasis. We will start treatment with the combination of different drugs. We will give a combination of different drugs and different types of therapies, that is systematic pharmacotherapy and rotational therapy. In systemic pharmacotherapy, we use immunosuppressants and immunomodulators in combination with other drugs because psoriasis is an immunological disease. So, in order to control this disease, we have to use immunosuppressors and immunomodulators in order to reduce or does not provoke the disease. Along with these drugs, we will give the patient emollients along with mild to moderate topical steroids so that uh, this uh, um, this will resolve his the problem with itchiness and rashes, and also gives comfort to his skin. We will also use bed dressings and referrals their nutrition. Our plan is divided into the two categories. First one, we would like to discuss the pharmacological plan. We will treat him by the following medicines, that is methotrexate, cyclosporin, oral retinoid, and infliximab. Now the doses we will give the patient are methotrexate once in a week, tablet by oral 10 to 25 milligrams. Now we will give cyclosporin in the manner that the maximum initial dose is 5 milligram per kg per day, subsequently adjusted during the course of treatment and the clinical response, and carefully monitored every month. After the improvement of patient's condition, we start to taper off the medicine by decreasing its dose, that is 0.5 milligram per kg every 2 weeks. Our oral retinoid is given in a manner that it will give in the combination with UV phototherapy, slowly increase the dose and start with minimum, that is 0.7 milligram per kg per day, in order to not provoke the disease. Infliximab is used in the patients who are responding less to other systemic therapies. 5 milligram per kg IV at first, second, and sixth week. Then our non-pharmacological treatment would be admit him to the hospital if he is unwell. Complete bed rest. Patient should be given complete bed rest. His fluid balance and temperature should be monitored. Review his medications time to time, that whether some medications need to be added or omitted. Treat other underlying conditions that can trigger or increase his skin condition. So that's why underlying conditions should also be monitored. Now, the test recommended for this disease is the biopsy, and the blood cultures is febrile. CBC is eosinophilia, lymphocytosis, skin swabs, and ECG if the patient is elderly. Thank you so much. This is all about my drug and its related case study. Allah Hafiz.